All right, so a few things to start with, always housekeeping. We talked about the exam. From now on, I think I will open the download window the day before. If you could download it before, the day before, and if there's issues, that way I can solve it and we can get started on time. It just makes your anxiety go up when things are not working well. And plus it takes our class time away, and now the real fun begins. So I will, when we do exam 2, I'll put an announcement. We'll review that in class, but I'll have you start the download the night before. I was going to say we can move to a different classroom, but looks like the gods have smiled on us now rather than during the exam.
I think he said he was going to tell them. Like, oh, that's silly.
Yeah, yeah, that was annoying. All right.
We should redo the exam.
You know, but I'll make it a harder exam, and they'll all be multiples.
They're all going to be filling the
Yeah, fill in the blank. That is my favorite. So the next unit covers chapters 11 through 21. The exam does include chapter 10 again, which is the opioids and the acetaminophen. I don't make the exam. They just,
exam 2?
yeah, they throw it in on both exams. Go figure.
You said 11.
11 through 21. So anesthetics, central nervous system depressants and muscle relaxants, central nervous system stimulants, anti-epileptic, anti-Parkinson, psychotherapeutic, substance use disorder. And then all of the drugs that we go over related to the autonomic nervous system, which are adrenergic and adrenergic blocking, cholinergic and cholinergic blocking. Do not miss class during that time because most people really struggle with those concepts. That's a lot of information. It is nothing like what we've been doing right now. Start learning it right away because there's no way you can learn it all in the weekend before the exam. It's just too much. All righty, so we are going to talk about central nervous system and general and local anesthetics. All good stuff. Let's see, we'll turn it out. It's not the right one.
No more. No more shoulder.
Well, probably more later.
All right.
Well, so by the time we're going,
That was all just a little bit of chaos. Right. All right. So as we have talked about, analgesics and anesthetics are similar related, but anesthetics not only reduce or eliminate pain, but act either at the central nervous system or the peripheral nervous system and depress essentially the central nervous system function. So that's a pretty big deal. So since you've read the chapters ahead of time, theoretically. So everybody's probably had a local anesthetic, right? You get that at the dentist's office. And anyone who's had surgery where you're out has had general anesthetic. So I guess I've already kind of told you a common use of a local anesthetic. We'll just go ahead and kind of go through them. So I like to think of them kind of in order from most suppressive on down. So general anesthetics, of course, you're completely unconscious because you don't want to be conscious when they're, taking your gallbladder out generally. You lose your body reflexes and you have paralysis of your muscles of breathing. So that's a pretty serious state to be in. You are an OR nurse, you're going to have some things you're going to be responsible for. Moderate sedation is also called conscious sedation. So that's sort of a midway between, and then regional is also called local. Why does there have to be multiple names for the same thing? And of course, locals are like, you're going to have a boil or a splinter, big piece of wood that you have embedded in you. You're going to have that removed. So they're going to give you a local injection so that we can just anesthetize the nerves around it. You're still conscious, right? And then there's this sort of hybrid called monitored anesthetic care, MAC, which is a regional anesthetic along with sedation. So the medications that we do here along with a drug to sedate you. It's a hybrid form. So let's look at the general anesthetics. Of course, we want to depress consciousness so that people are not awake and hearing all your chatter in the OR. We want the skeletal muscles to be relaxed. Of course, you don't want a patient whose muscles are all rigid. We don't want any reflexes. The last thing you want your surgeon to have to deal with is your reflexes jumping while they have a scalpel over you, right? So we want to suppress the reflexes. You have pain relief. So there are three general types: inhaled, parenteral, and then adjunct. All right, so here's the start out question. Something called balanced anesthesia. The nurse anesthetist, of course it's a nurse, right, is planning to use balanced anesthesia during a surgical procedure. The characteristic of this type of anesthesia is it the administration of minimal doses of multiple anesthetic drugs, the administration of inhaled anesthetics, IV administration of anesthetics, or administration of anesthetics to cause muscle relaxation? Yeah, I mean, it's kind of just by definition. Just like we said with pain relief, low doses of multiple medications generally works better and has less side effects than a large dose of a single. So that's why anesthesiologists like to use small amounts of multiple medications. That's the answer there. So general anesthetics are very systematic and orderly in how they suppress our function. We lose autonomic and then sensory and then motor function. And then when it returns in the opposite order. So our heart and lungs are the last ones to be interrupted. So kind of learning the order of suppression, we lose our senses, and then lose consciousness, and then our muscles relax. And the last thing is like pulmonary and respiratory, pulmonary and cardiac suppression. When assessing a patient under general anesthesia, which change to organ systems does the nurse expect? So you're the OR nurse. What do you expect to see on the patient being anesthetized? Do they vasodilate? Do their skeletal muscles contract? Are they hypertensive? Or do they have decreased intracranial pressure? Thinking A? Yeah. So generally speaking, all of these things happen. We're vasodilated, skeletal muscles are relaxed, and the vasodilation occurs because the muscles that cause vasoconstriction are anesthetized, right? So it's all muscle relaxation. Vasoconstriction or vascular tone is maintained through muscle tone. So if you anesthetize it, you no longer have vascular muscle tone and everything relaxes, you vasodilate, which gives you hypotension, but you get increased intracranial pressure because you're vasodilated in a closed environment, right? Your skull can't expand. So if you're vasodilating inside of a closed container, our pressure increases in there. So you should know all of the desired and undesired things from being under general anesthetics. We like it because we can get people under quickly. It's out of their system quickly. We don't have to deal with the patient saying, hey, what are you doing back there? You know, they're unconscious, they're relaxed, everything, you know, you can do anything you want. You could sew their leg to their ear if you felt like it. And we also use general anesthetics when we're doing electroconvulsive therapy for people with really severe refractive depression who failed all sorts of pharmacotherapy. They get anesthetized. We interact with blood pressure controlling medications, right? Antihypertensives. Same word for blood pressure reducer. Lots of patients don't understand what an antihypertensive is. You as a nurse should know the term, but when you talk to patients, you should be saying blood pressure reducer, right? So why does an antihypertensive interact with a general anesthetic?
Just reduce things.
You've already got vasodilation and low blood pressure from a general anesthetic, and now we're gonna lower your blood pressure more. Yeah. And beta blockers. We increase myocardial depression. Myocardial is muscle of the heart. We have increased myocardial depression. We'll just kind of go with it. So I was getting a citation for this. So all anesthetic agents, one way or another, depress the electrical activity to the heart muscle. So just like we had seen in the order of suppression with autonomic and then sensory and then muscle and then cardiac gets suppressed with a general anesthetic. We know it's going to suppress cardiac activity, and a beta blocker, when we get to that, is a drug that slows the heart rate. So even though we haven't talked about beta blockers, I do expect you to know beta blockers slow heart rates. They interact with anesthetics that also suppress heart activity. During surgery, the anesthetist notes that the patient's heart rate is gradually increasing and becoming more irregular, and the patient's blood pressure is getting unstable, and they're starting to sweat. What other assessment should the anesthetist note immediately? Respiratory effort, temperature, pupillary. So this one is actually answer C. It is temperature. These symptoms are all an indicator of a condition called malignant hyperthermia. So we have an increased heart rate, we have an irregular rate, rising blood pressure, and an increase in core body temperature, usually above 40 degrees Celsius, whatever that is in Fahrenheit.
104.
Okay, super high temperature. So the exams of Elsevier people love to test on malignant hyperthermia. However, it is a really rare thing that happens, and it's genetically linked. So you may or may not ever see this in your entire career, but you're expected to know what it is. So it occurs either during or after general anesthesia, or if we use neuromuscular blocking drugs, which we'll talk about, especially succinylcholine. So elevation in body temperature, I mean, that's hot. You'll touch them and they're hot. They're burning your hand. Rapid breathing, rapid heart rate, stiff muscles. Classic signs you have to know of malignant hyperthermia. This is a life-threatening emergency. All medical facilities that are putting people under anesthesia are required to have doses of the antidote available on hand. And the antidote, yep. We having an earthquake?
Well, it might as well be.
Upstairs.
Okay, I was thinking I was my vision.
No.
So the treatment for it is a skeletal muscle relaxant. And the skeletal muscle relaxant is dantrolene. Every medicine that has an antidote, you are expected to know. All right, general anesthetics inhaled. So the most common inhaled gas, of course, is nitrous oxide. And then there's a list of inhaled volatile liquids. And really, we're probably only going to talk about one. And if there's a reason that we even mention it. So laughing gas, the little mask they put on you at the dentist's office, it never made me laugh. It's the weakest of all the general anesthetic drugs. It's the only inhaled gas on the market. So it's really the only one they can test you for. And they can use it as a supplement to more potent anesthetics or just by themselves. The volatile liquid that we mentioned is this sevoflurane, which is fluorinated ether. Ether is one of the original anesthetics that we came up with back in World War one of the world wars, where they had to put drops of ether over a cotton mask and monitor the number of drops per minute. Well, we got a little more clever in how we use this medicine. We like it because it's we can use it in outpatient surgery. So rather than in general surgery in the OR, we can use it for outpatient procedures. And it's rapid onset, rapidly out of your system. We do like it in pediatric patients because it's inhaled rather than injected, right? Nobody wants mom to hold down the kid while we inject them with something.
So it's an inhaled liquid.
It is inhaled volatile liquid, right? But just like an inhaler medication can be a liquid, right? Once it's activated, you are able to
So it's
inhale it.
it's like comes in a compressed can.
No, it's not gonna. It's not gonna be in a compressed. It might be in a like nitrous. No, it might be in like a nitrous oxide air, metal container in order to hold it in under pressure.
So it is under pressure.
I would assume, but it also, I have not been on the administration end of fluorinated ether. So that's a good question. Those are good questions. Tattoos, all these things. So that's the one I would just remember that's good for use in pediatric patients. That's kind of the key about that one. Then we have the parenteral, which obviously means it's getting into the bloodstream more directly. We do like it because it has these amnesia effects where people don't remember what's happening. So we usually use it as an adjunct in balanced anesthesia. The examples are ketamine and propofol. So everybody knows ketamine. It's like the big rage nowadays for everything that ails you. So we use it to get people to render people less conscious and to give it an amnesia effect. Right. So ketamine, just the general things about it. It's a fairly safe drug. We don't have a lot of problems unless we don't know that the patient's on certain medications, drugs, or if they just respond erratically. Low incidence of heart and breathing problems. Given IM or subcutaneously or IV, so lots of ways to do it. Adverse effects can include things like hallucinations, but if that's your main problem, as long as it's not a scary hallucination. Propofol, again, used to initiate and maintain anesthesia. Propofol is also used to sedate people for mechanical ventilation in the ICU. You certainly want your patient sedated while they're in this critical state and not trying to fight what's happening. So it does get used in lower doses as a sedative, hypnotic. Sedative meaning reduction of anxiety, and hypnotic meaning inducing sleep. So Michael Jackson, that's why I put him up here. He died of a propofol overdose, being administered for sleep in his home. That's one way that I can remember things. It's like with some picture. So it relieves anxiety, but it doesn't relieve pain, right? It relieves anxiety, helps induce sleep, but there's no pain control. So if you need pain control, you have to take another medication. All right, we're adjunct drugs. So adjunct drugs are anything that you add on to another drug, right? And there's a whole bunch of things that can be used. We will be talking about shortly barbiturates and benzodiazepine, and hydroxyzine is a medicine used for nausea and itching, and promethazine is a medicine used generally for nausea, but it's a central nervous system depressant. So that's why we can combine it with other anesthetics. Opioids get used as adjunct drugs because, of course, propofol doesn't have any pain relieving properties. So it's nice that we allow people to have some pain relief when we're doing things to them. We're going to talk about these neuromuscular blocking drugs, which are called NMBDs. You'll see that acronym all the time because this is just way too long to say and to right? It just gets called NMBDs. And there are a couple of categories. Mostly we'll talk about succinylcholine when we get to it, and then some other drugs in a category called anticholinergics, which we will see in chapters 20 and 21. So all of this kind of ties together, even though you don't know what it is now, it will all make sense once all the information is covered. Wow, it's a blank slide. End of general anesthetics though, because it starts to get confusing unless I put a break in there. All right, moderate sedation, also called conscious sedation or procedural sedation. You're not completely asleep, you're aware of what's going on, but you're less anxious, you have less pain, and the best part is you can't remember what happened, right? So moderate sedation is generally what you get for a colonoscopy, because nobody wants to remember that. Usually we combine a benzodiazepine and an opiate. So this is the common one. We'll talk about benzos in central nervous system depressants, midazolam, and then an opiate, and then possibly IV propofol, because propofol didn't have any pain relieving capacities, but we would use lower doses than for general anesthesia. So propofol high dose, general anesthesia. Propofol low dose, we use it as moderate sedation. It's all just a bunch of things. You may need to make charts in order to know where things fit. I'm not sure how you learn best, but yeah. So they can keep their airway, where with general anesthesia, you need help maintaining an airway. These people can maintain their airway. They can respond to you. They have a rapid recovery time, great safety profile. Generally, people have no problems with it at all. We use it for diagnostic, like I say, we use it for colonoscopies. It's the most common things out there that people don't need to be deeply anesthetized. All right, conscious sedation, which is accurate. The IV route of drug administration is commonly used in pediatric patients to provide conscious sedation. Mild amnesia is a common effect of midazolam. Patients receiving conscious sedation must be intubated with an ET tube, or effects of propofol include relief of anxiety and pain. And you can automatically kind of eliminate some. If you don't know what the right one is, you can eliminate some by knowing what the wrong one is, because we know that propofol doesn't relieve pain. So automatically you can rule that one out. We know that the oral route is preferred in pediatric patients, the oral inhaled route, right? IV is like the worst route ever. It's the last choice. And we know that people who have conscious sedation can maintain their airway. So by default, if you didn't know this, that's how you could come up with the midazolam answer. And of moderate sedation. Right. Regional or local. So obviously we just want to make a certain part of the body where we're going to monkey around. We want to reduce the pain sensation. Obviously, if you're injecting somebody in the foot because you're excising something, they're not going to have a loss of consciousness. Well, they might pass out, but generally speaking, that's not a result of the drug. So these are the kind of the categories we talk about: nerve blocks, spinal or intraspinal. We don't really speak a lot about that. Infiltration and topical. So these are types of local anesthesia. We use them for dental and diagnostic procedures, so you can already think what one would be if it's a dental procedure. What's one of the drugs? What does your dentist give you? Novocaine. Oh, not my. Novocaine, right? Novocaine is the drug injected to numb the nerves around your jaw. We use local anesthetics for some types of chronic pain. So some people will have a spinal cord intrathecal injection of something in order to treat chronic spinal pain if they have spinal stenosis or something. And of course, we use it in childbirth, surgical procedures. I already said how they're given. So we have localized for paralysis. So basically, depending on how deep we're treating something, if we're injecting something deep into a muscle, you're going to have paralysis in the area of that muscle. If it's just under the skin, then the muscle obviously isn't paralyzed. So less important. Let's talk about the problems with local anesthetics. So if it is injected and we accidentally get it into, if it was an IM injection, we accidentally get it into the vein, right? Big deal. We don't want to get lidocaine intravenously. There are cardiac problems with that. So if you were intending to get it intramuscular or even intradermal and actually got it IV, big deal. Or if we're injecting it into really vascular tissue, there's a risk of a lot of systemic absorption, problem. Everything should start low and go slow. You want to give the right dose, nice and easy. Some people don't break it down very well, the rate of metabolism, which we talked about, how everybody metabolizes drugs at a different rate based on age, genetics, and whatever drugs they're taking besides it. And then allergies. So there are people who have allergies, allergic reactions to local anesthetics. I'm one of them. I got allergy tested. And most common are ester types. And yes, you do have to know this. So I try and make it a way that you can learn it. Okay. So here's a family of drugs. They all end in cane, right? This is the cane family. And here's anti-ester and anti-amine. Well, anti-ester has problems and most people are allergic to ester drugs. So the way that people generally learn it is if the word has a single I in it, it is an ester. And it is a drug that people can be allergic to, more likely to have an allergic reaction. If there are two I's in it, then it falls into the amine class, less likely to have an allergic response. You do have to know that esters are more likely to, people who are injected with esters these drugs are more likely to induce an allergic response than amine, and you need to know how to identify it.
The double I is the amine.
One I is ester, and one I is ester, and she's the one that everybody's allergic to. So I'm allergic to benzocaine. One I. Two I's in there, lidocaine, ibocaine. So which one is chlorprocaine? One I, right? Which one is procaine?
So what is that one, the two I's?
Two I's is amine. Ester and amine, the classes of canes.
What does it mean? You don't more, so the one I, more people have an allergic reaction.
Right.
Two I's.
Two I's is less likely to cause a reaction. So let me just use myself as an example. So when I go to have a surgical procedure and they say, are you allergic to anything? And I say, yes, I'm allergic to benzocaine. Okay, they know that I'm allergic to ester, but generally they can give me an amine and I won't have an allergic reaction. Yeah. Clear as mud? All right, let's learn about spinal headaches. So anyone who undergoes a dural puncture, which is inadvertent during an epidural procedure or an interthecal procedure, 70% of those people end up with a spinal headache, which is like the worst headache of their life. That's how they describe it. It usually goes away on its own, and the treatment is bed rest, pain relievers, and caffeine. For people who have a really bad case, they may do a blood patch in order to try and patch that puncture. But most people just bed rest, analgesics, and caffeine. So you've got a patient who's going to have a procedure, and you're talking about spinal headaches. Which statement do you include? Spinal headaches can be prevented with bed rest after the epidural procedure. Patients who have spinal headaches should limit their fluid intake. A graft of skin from the patient's hand can be used to seal the leaking area causing the headache. or a high Fowler's positioning should be used for patients who have a spinal headache. This is asking you to know a lot of things, right? You need to know what high Fowler's position is. So generally speaking, your patient is coming in PACU or coming to the floor and they've had a procedure. Their orders are going to be for a certain period of time to remain flat in bed. And that will generally prevent a spinal headache.
So it's the people that get up and walk around that they get those.
Well, I mean, it just increases the chances. We increase fluids after a procedure. We don't withhold fluids. We don't use a skin patch. That was sort of a distractor to see if you were paying attention in the question that you saw a patch and they say, oh yeah, we give them a patch. What's a blood patch? It's not a skin patch. And then, yeah, they should be positioned flat. And oftentimes if they have one, if we just have them lay flat, it'll go away. So you should know spinal headache, definitely. It's like malignant hyperthermia. It's one of those things they like to test you on. The most commonly used local anesthetic is the amide class. Is amide more or less likely to induce allergies? Less, thank you. We use it often with epinephrine. Any idea why we use it with epinephrine?
It makes it last longer.
Yeah.
Or it enhances the lidocaine effect.
So epinephrine is a vasoconstrictor. So we will get less bleeding. It may hold the lidocaine in the area longer. So that's why we often use epi with lidocaine. And then lidocaine is available in so many forms, right? You can get it just about any way at the grocery store. Comes in roll-ons, comes in patches, comes in gels and creams. It comes in a tube to put on your tooth. It's the most common one out there. All right, and remember what did we say about the patches with lidocaine? What's the rule of the lidocaine patch? How long should it be placed on?
12 hours.
There you go, 12-hour on, 12-hour off. All right, this is the neuromuscular blocking drugs. So we want to use this especially for people who are intubated because we need muscle paralysis. We don't want people fighting ventilation, and we use it with the anesthetics during surgery. We use it because it paralyzes the muscles of breathing, right? That's our little picture. So anyone who's having surgery is going to be on a neuromuscular blocking drug, and you're going to have ventilation. These are like the three things that go together: general anesthetic, neuromuscular blocking drug, ventilation. Because all of their muscles are paralyzed, the muscles of breathing are paralyzed, you have to have ventilation. So if this medicine is being used outside of an OR setting, there has to be emergency ventilation immediately there, right? So what's different about these drugs is that it's just a muscle paralyzing drug. That's it. That's all it does is paralyze your muscles. It doesn't cause you to be sedated. It doesn't relieve pain. All right, that's kind of scary. That's why it has to be used with sedation. That's why it has to be used with pain relievers, because all it does is paralyze muscles. All right, this is kind of the order of operations, how things get paralyzed. Kind of starts peripherally and works its way centrally. So starting with fingers and eyes, and then sort of neck and trunk, and then into the central intercostals and diaphragm, and then when you recover, it recovers in the reverse order. So if you're the nurse in the PACU who's monitoring someone who's waking up from surgery, you need to be watching the recovery as this drug is metabolized through their system. Are they recovering their limbs, neck, and trunk, and then their fingers and eyes? If they're not recovering their fingers and eyes, well, something's going on. One of the side effects of this is that people who are recovering from it, they may have like rebound firing. Remember that picture back here where there's kind of this firing that gets blocked. So that's where the neuromuscular blocking drug is blocking that signal. So people who've had a neuromuscular blocking drug, once it's wearing off, they may get an overstimulation of signals and have some muscle twitching and a lot of it, and it can cause muscle soreness. So muscle twitching is sort of a normal thing you might see in someone recovering. And if they are sore, it's maybe something that you would have explained before the procedure or after. So the drug we talk about is succinylcholine. So when we get to the neurotransmitters for the parasympathetic nervous system, we'll talk about acetylcholine. This is a naturally produced substance in our body. It is metabolized slower than our own body's production of acetylcholine. So as long as this drug is present, that impulse is blocked. As long as it's present, the impulse is blocked. So it basically gives a, what is flaccid? What does it mean when we say flaccid muscle paralysis? Yeah, like you're limp. I mean, you wouldn't want stiff muscle paralysis. You want to be able to move everything any direction that you can. So we don't give succinylcholine back. So flaccid muscle paralysis. Yeah, we don't give medicine that causes flaccid muscle paralysis in malignant hyperthermia. It's a contraindication. We give the skeletal muscle relaxant. Anybody remember what the skeletal muscle relaxant was? Dantrolene, right? So if somebody we're just kind of tying it back together. We don't use this particular drug, succinylcholine, we use dantrolene. So if somebody is overdosed on it, we do have antidotes, which are neostigmine and pyridostigmine. And you will see these drugs when we talk about myasthenia gravis, which is in this unit. So the antidote to succinylcholine is a drug that's used in myasthenia gravis. So you could see if there was something to do with myasthenia gravis, we might have a use for succinylcholine in reverse. The two are related. So learn your antidotes. Let's see. Patient's going to get their AMBD. You're telling them about this. And while they're on this medicine, the nurse should expect the patient to be. So it's basically asking you what's the function of a neuromuscular blocking drug? That's what that question's asking. Or does it cause you to be sedated? Are you now resisting the ventilator? Are you awake, unable to move? Are you pain-free? Right? We know that it doesn't cause sedation. We know that it doesn't cause pain relief. So by the process of elimination, we know what it does do. All right, we're gonna actually skip this. So why should we assess the history of someone's response to anesthesia? Okay, they could have an allergy. That's a good point. Okay. How did they respond to the anesthesia the last time? What is the one condition that was life-threatening that we just recently talked about? Where the symptoms were malignant hyperthermia, where the symptoms were. So if someone has a history of malignant hyperthermia, we should probably know that. Or if they have a family member who has a history of malignant hyperthermia, it's genetically linked. So we should know that. Your anesthesiologist would really appreciate if you do a really good history taking. And then all of these things, people don't want to confess, what they're using or what they're taking, but just a simple, non-biased explanation as to why you're asking, because all of these are central nervous system depressants, and we don't want you to die on the table because we don't know that you were taking what A, B, or C, right? Just all non-judgmentals, hey.
I have a question.
Yeah.
So the surgeries like C-section are types that are part of coming out of anesthesia?
I wouldn't think so. Did you have a personal experience?
Yeah, so I had like severe types for my
mean, it sounds like allergic
Was,
reaction to
but
me.
They never said anything. I'm like, there's nothing to bring up.
They're like, well, she didn't die, so let's everybody shh.
Yeah.
I don't know if it's a metabolism of one of the drugs given to you that as you're metabolizing it, one of the metabolites you're sensitive to. I just, anytime if you were ever going to undergo any sort of procedure, I would always mention that, hey, when I was, blah, 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 as I was recovering, I had, massive hives. And let the anesthesiologist decide if there's any clinical significance, but I call that an allergic reaction.
I know like itchiness is a symptom, but I didn't.
Yeah,
I wasn't sure,
hives.
Like hives seems like.
Yeah, hives, itchiness, rash, yeah, they're all considered signs of an allergic reaction. It really is. So obviously, if you're the OR nurse, we're monitoring, your anesthesiologist is monitoring these things. But what if you're in post-op, right? They're expecting you at very frequent intervals to be looking at the vital signs, the machine is monitoring, obviously checking temp, because malignant hyperthermia can happen both during the procedure and in the recovery phase. So they may have got through the procedure just fine, and all of a sudden, now we're having issues. We're not going to go through each of the drugs and all the steps that a nurse should know for the various, different types of. Every procedure has its own protocols associated with it. They're all really complex. You will be educated on it. You will not be tested on it. So we're just kind of keeping it simple about here's the drug, here's the risk, here's the antidote. We're not going to go through, here's the procedure that this patient is having this and that procedure. They're going to get this drug. It's much simpler than that. Patient in the ICU is getting an NMBD. Which piece of equipment do you have to have nearby? What does an NMBD do? NMBD, neuromuscular blocking drug. If you immediately know what this is, neuromuscular blocking drug, you say if I block the neurons to my muscles, right? I'm paralyzed, I can't breathe. I can instinctively know I need a ventilator. It's better to learn it, but that's how you kind of figure those things out, right? You have to have your ventilator. So this is one step. This will be the last thing we do, and then we can't even get to chapter 12. But I expect you to have read it because we're going to do a Jeopardy game when we come to class on Monday, all about these two topics. You are the OR nurse assisting with a surgical procedure. They're unconscious, getting general anesthesia. You touch the patient. They feel hot, they're tachypnic, they're tachycardic. What do you suspect? Right, we've said this probably 10 times now, which means expect to see it. Obviously, we expect malignant hyperthermia. It is potentially fatal, right? And we need to know the signs and symptoms. So in addition to doing your role and whatever support that you need to provide on a cardiorespiratory basis, you should prepare to administer what antidote? I know your antidote. Malignant hyperthermia is treated with dantrolene. I think I've hit this home enough times that you should know what malignant hyperthermia is, what neuromuscular blocking drugs are. So the patient's going to pack you. The patient is stabilized. What other teaching do you need to give this patient regarding the fact that they had malignant hyperthermia? Right, we would want to make sure that they know that this was a result of anesthesia, that it can happen again, so that they need to anytime they might have a procedure, make sure the surgeon knows, right? And they also should make sure their family knows, because it's genetically linked. People at greatest risk are children and teenagers and anyone with a muscular or skeletal abnormality that are at higher risk for this happening. All right, you're out of here. Deep breath. Breathe, breathe. study, study.
No.